Hello, everybody. My name is Austin Orsini, and today I'll be talking to you about atrial fibrillation. What is atrial fibrillation? Atrial fibrillation is an arrhythmia of the heart, the most common arrhythmia of the heart, and it originates at the SA node in the right atrium. It essentially sends out rapid impulses from the SA node that make the atrium contract at a very, very rapid sporadic pace. Common names for AFib, or for atrial fibrillation, I should say, are AFib and AF. There are two different types. There's controlled AFib, which has a ventricular rate of less than 100 beats per minute. And there is uncontrolled AFib, which has a ventricular rate of greater than 100 beats per minute. There's four classifications of AFib. There's paroxysmal, which has a start and stop suddenly type pattern, very random. There is persistent AFib, which has been sustained for greater than a week. There is long-standing persistent AFib, which has been sustained for greater than a year. And there is permanent or chronic AFib. So here's to see a picture of normal sinus rhythm. This is just to give you an example of what exactly happens throughout the heart. So you'll see here that the SA node, originating in the right atrium, will send an electrical impulse from the right atrium, depolarizing the atria, to the AV node, which is then sent from the AV node throughout the ventricles to allow the ventricles to contract as blood is filled into them. So you can see that on the EKG here, that you have a P wave right here, which shows the depolarization of the atria, then the QRS complex, which shows the depolarization of the ventricles, and then the T wave, which is just the repolarization of the atria. Everything is normal here. There's a rate of about 60 to 100 beats per minute, so obviously nothing to worry about. Now on the flip side, on the right you'll see you have atrial fibrillation, and then on the left you'll see the normal heart and EKG reading that you just saw. Now on the right you'll notice that the SA node does not have electrical impulses coming directly from it, rather than it has rapid random electrical impulses throughout the entire atria in both of the left and the right atrium. Some of these electrical impulses make it to the AV node and some of them don't. You'll notice that in the EKG reading you have a very, very rigid and bumpy baseline, whereas on the left for normal sinus rhythm you have a flat baseline. So that is how you can very, very easily identify it on an EKG reading. Now the prevalence of AFib. So as I said before, AFib is the most common heart arrhythmia. It's estimated that 2.7 to 6.1 million people in the US are living with AFib. Of those people, only about 2% or less are under the age of 65 years old that are diagnosed with AFib, and about 9% of people that are older than 65 are diagnosed with AFib. So you can see that age becomes a factor. Also, both men and women have an increased risk for AFib as they age, as you can see in this chart to our left. But it's known that women are tending to live longer than men now, so as they get older, more women than men are noticed with AFib as of recently. Some complications that could arise from AFib. So when the atria depolarizes at a very rapid rate, it doesn't allow all the blood that enters the atria to get to the ventricles. This is very problematic because it has a decreased cardiac output, and when there's a decreased cardiac output, there's a very limited oxygen supply that gets to your body, which could contribute to a lot of the fatigue and lightheadedness that one may feel. And then also problematic because blood pools in the atria when not all of it can go to the ventricles, and that could cause a thrombi or a clot to form. And if that thrombi was to get out into the bloodstream, there's a chance that it could actually reach the brain and cause a stroke. A few general symptoms of AFib, aside from looking at an ECG, which is probably the easiest way to actually notice AFib. There's general fatigue, rapid heartbeat, dizziness, shortness of breath, weakness, chest pains, and fatigue when exercising, which again all makes very good sense when you think about the limited amount of oxygen supply going to the body. A couple risk factors that go into atrial fibrillation. So as we already said, age is probably the number one risk factor. Sex, which we see men and women have it. So diabetes, hypertension, valve disease, heart attacks or heart failure, and then other things such as obesity and activity. 60% of the time when an AFib is diagnosed, there are more than one issues being present at the same time. So, for example, somebody that's much older, say 70, 72 years old, with hypertension. Hypertension is responsible for 14 to 22% of AFib throughout the world, and therefore, if you're older and have hypertension, there's a very, very, very good chance that you're going to develop AFib. Some treatments that could go into AFib. So there are medications to take that manage the heart rate and rhythm. So some of these medications would be a beta blocker, which would allow suppression of the sympathetic nervous system, limiting the amount of epinephrine and lowering blood pressure and heart rate. Calcium channel antagonists do a very similar thing to control the rate of the heart. Blood thinners, which would decrease or manage the risk of clotting and stroke, such as aspirin, is used as a good blood thinner. And there's also a couple surgeries or procedures that can be done for AFib, such as cardioversion and radiofrequency catheter ablation. Along with those three active treatments, there are also general lifestyle changes that can be made to alter the effects of AFib and kind of reverse them. So during exercise, AFib is obviously going to be a factor. Symptoms can arise if workload is too much too fast. So if you do too high of an intensity with AFib, there's a good chance that your heart rate and blood pressure are going to kind of spike, in which case you could end up becoming very dizzy or lightheaded or even faint or cause some sort of heart issue. And then there's also symptoms to look forward to that could actually restrict the potential, which is what I just said. You have heart palpitations, dizziness, shortness of breath, anything that looks like it should be a sign that you're going a little bit too hard, too fast. And then there's the effects of exercise on AFib are, like I said, you kind of reverse the effects of the AFib. So if you, on the left here, you'll see a diagram of somebody that's obese with AFib. And you'll see that with just right up top, you have just regular weight loss, which actually reverses the cardiac remodeling in itself. But then at the bottom, you have exercise training, which improves cardiovascular risk factor burden, so there's less of a risk factor for the cardiovascular system. You have improved cardiovascular fitness, and you, again, just like weight loss, reverse the cardiac remodeling. Also, there are short-term benefits of training, such as reduced burden of the atrial fibrillation and reduced symptom severity, and that's in less than 6 months of exercise. There's long-term, which is in increased freedom of atrial fibrillation, which actually is pretty much saying that you don't really have it anymore. And then there's also reduced symptom severity, which again is just limiting the amount of symptoms that you feel throughout the day and or throughout exercise. So here we have a case study, and we're going to put together what we just learned about into actually treating a patient. So George is a 65-year-old, 5'10", 245-pound male with sporadic episodes of an irregular heartbeat that cause shortness of breath and general fatigue, but doesn't seem to have any chest pain. After being tested over the course of a year by his physician, the ECG readings clearly show an episode of atrial fibrillation. During his last doctor visit, his blood pressure was measured at 150 over 82, and his resting rate was measured at 86 beats per minute. George was prescribed metoprolol to try to combat his hypertension along with his elevated heart rate. He also started taking 225 milligrams of aspirin daily to thin his blood in order to prevent clotting during these episodes of AFib. George has no family history of coronary artery disease and is in a good standing health otherwise. Okay, so some things to think about here. So George is 58 years old, 5'10", 205 pounds, with a BMI of 29.4. He's on metoprolol, which is a beta blocker, and therefore we know will not show an accurate heart rate or blood pressure reading because his sympathetic nervous system is suppressed. He has a ventricular rate of 86 beats per minute, and so therefore it's controlled AFib, and he has no history of coronary artery disease in his family. So from there, we would start an exercise test. Again, things to consider for the exercise test is that George is on the verge of being obese. He is hypertensive. He has an elevated resting heart rate, controlled AFib, and he's on a beta blocker. Therefore, when you're on a beta blocker, it is necessary that you use a rate of perceived exertion scale or an RPE scale to identify the intensity at which the patient is working at, because heart rate reading is not a true assessment. So for George, being that he is an older patient, I would have him do a 6-minute walk test, and I would assess his blood pressure and heart rate before, during, and after the test. And I would also take an ECG reading at rest, during, and post the test. And that would be for his cardio fitness. And then for his resistance training, I would do a bodyweight squat test just to have a general understanding of the kind of strength that he is capable of and what we should be prescribing him so that he doesn't go too intense too quickly. Some other things to consider when exercising with atrial fibrillation. Cardiopulmonary fitness is known to reduce the risk of diseases such as hypertension, diabetes, and obesity. So with the AFib, cardio fitness is good because he has hypertension as it is, so we can lower that potential and possibly eliminate the hypertension. He's most likely to have a lower VO2, which again goes back to the cardiac output being much lower. So there is a limited amount of oxygen that is supplied to the body. And then he has to start at a low intensity, low impact exercises, because if going too hard too fast, the heart could actually spike in heart rate and blood pressure and cause much greater issues to occur, especially considering he's on a beta blocker. So we don't want to push him too fast without him actually knowing what his body is physiologically doing. So here we have the ACSM guidelines for hypertension. This is just to give a basic background and idea of what we could be doing to combat his hypertension as well as his AFib, because they kind of go hand in hand. So aerobic, we're going to do 5 to 7 days a week, resistance 2 to 3 days a week, flexibility about 2 to 3 days a week. We're going to start lighter intensities because of his AFib and he's older. So we'll see here on the next page. We have George's exercise prescription. So for his cardio exercise, we're going to have him do 5 days a week at an RPE of 5. Just a light walk outside for about 15 minutes a day to start. For resistance training, we're going to have him do squats, lower extremity work, and upper extremity work 3 days a week. We're going to start him at about 60% of the total number of squats that he did during his test. And he's going to do about 3 sets. For his flexibility, he's going to do the V-sit, posterior quad stretch, and that's going to be 2 days a week. And then his balance, he's going to do the single leg stand and tandem balance for 3 days a week. And you're going to increase the intensity weekly or as often as he may seem fit. Thank you guys for learning about atrial fibrillation with me. I hope you guys learned something.